All right, so this is the third part of our COPD series. This is over maintenance therapy and pharmacological therapy for COPD by me, Nick Riesenberg. So medication use in COPD maintenance, you're going to use a short-acting bronchodilator or beta-2 agonist, short SABA, or a long-acting bronchodilator or beta-2 agonist, a LABA. And then as it progresses, you can use the long-acting muscarinic antagonist, which is a LAMA, and then you may even implement an inhaled corticosteroid, ICS for short. So bronchodilators, they're medications that increase the FEV1. They act by altering airway smooth muscle tone, and the improvements in expiratory flow reflect widening of the airways rather than changes in elastic recoil. So it's going to open up those constricted airways that are causing a problem with them being able to expire the volumes that they have in their lungs and give them a little bit more ease of breathlessness so they can breathe a little bit easier. They also reduce dynamic hyperinflation at rest and during exercise and improve exercise and performance. So short-acting, the SABAs, are rescue quick relief medications. They are indicated for treatment of acute episodes of bronchospasm, and they help relieve the feeling of breathlessness that COPD patients experience. So this can be very helpful for someone who's maybe in the mild zone. All they have is this for the quick relief when they need it. But even it can be helpful for people who are in the later stages, the more severe, just so they have something for that quick acting that can help them during an immediate exacerbation. So the long-acting bronchodilators are used for maintenance, long-term control medications. They're indicated for long-term control bronchospasms and patients with COPD. When you pair together a SABA and a LABA, the SABA will address the short-term, that quick relief that they need, and the LABA will address the long-term need to control those bronchospasms. So here's just a couple examples of SABAs. You have salbutamol or albuterol. You can use it as MDI, DPI, nebulizer, pill, syrup, or injection. Duration is 4 to 6 hours or up to 12 hours if you use an extended release. I think that would be more in the pill variety. Labalbuterol, used it as MDI or nebulizer, duration of action 6 to 8 hours. Phenoterol, MDI, nebulizer pill, duration up to 4 to 6 hours. Terbutaline, you see the options that you can use. You see all of them are really in that 4 to 6 hours. So that's the kind of quick relief, and it's working in that time frame. So with the LABA, yeah, our formoterol is a nebulizer. It can be up to 12 hours. Formoterol, DPI nebulizer, 12. Indacterol or olodaterol, both those can be used for 24-hour maintenance. So like you just take it the one time, that's your daily dose for that long-term bit of that broncho dilation. So that's where that comes in the key of using both. You got one for your exacerbation, that immediate need, and then you have one that's a control med that's just going to be working all day long for you, or at least half the day, to keep your airways open. So LAMA, that was another drug. That's the long-acting muscarinic antagonist, and it's another way of approaching bronchospasms via a different mechanism. They block the bronchoconstriction effect of acetylcholine and preventing acetylcholine from causing the muscles surrounding the lung airways to constrict. This in return helps to reduce the COPD symptoms. Types of LAMAs, you have aclidinium bromide, up to 12 hours, used by DPI, glycotropium, glycopyrronium bromide, DPI, oral solution is up 12 to 24, tiotropium, up to 24 hours, and then umecadinium up to 24 hours. So you see kind of they also have a longer acting, hence the long acting, that helps with the maintenance side of COPD. And then you have an ICS, inhaled corticosteroids. They're anti-inflammatory agents, excuse me, I'm sorry, I'm tripping over my words, with direct and indirect bronchodilating effects. ICS are mandatory for COPD patients that have asthma. So that's something you want to consider. If they have an asthma component with that, well, they're going to need a inhaled corticosteroid added to their regimen. So types of, you're going to use the ICS in combination with is something else. It's not going to be on its own. So types of combinations, you got the LABA. So that's a long-acting bronchodilator, beta-2 agonist. You got formoterol, meclizone, and duration up to 12 hours. Formoterol, budesonide, formoterol, and methazone, salmeterol, and fluticasone propionate, melantrol, fluticasone fumarate. And all these are up to 12 hours, and even with the last one, vilanterol and fluticasone fumarate, lasting up to 24 hours. So it's all with the maintenance of that bronchoconstriction for the COPD patient. So here's another form of the combinations. You could have the LABA with the LAMA and the ICS. So that's a Trelegy, fluticasone, umethadinium, lansoprazole, DPI up to 24 hours. The next one, beclomethasone, formoterol, glycopyrronium, up to 12 hours, and the last one up there, all up to 12 hours. So that's where you see the maintenance side of this pharmacological implementation here, is that you're controlling either 12 hours of their day or 24 hours of the day. So they're either taking that medication once or twice to help relieve those symptoms and give them some ease and relieve the breathlessness. So there's some factors to consider when you initiate an ICS treatment. You see it's broken down from strongly supporting or consider use or against. So if strong support would be if they have a history of a hospital of exacerbations of COPD, over 2 or more moderate exacerbations of COPD per year. If their blood eosinophil count, like we talked about earlier, if it's over 300, then you definitely want to consider giving them ICS, and history or containment of asthma. So if they have asthma, you want to consider doing that, or you might, or you want to strongly support. You want to consider if they have one moderate exacerbation of COPD a year and their blood eosinophil is between 100 and 300. Against using if they have repeated pneumonia, because it can cause a pneumonia over time. If their blood eosinophils are less than 100, and if they have a history of mild bacterial infection, because ICS can contribute to those. So other adverse reactions, oral candidiasis, is thrush, it's where you have an issue in your mouth, you get dryness and it's like a fungal infection. Hoarse voice, because it's always going through your airway here. Skin bruising, pneumonia, as I already talked about. You can have increased risk of diabetes or poor control of the diabetes, cataracts, the mild bacterial infection, and tuberculosis. So, okay, so we've talked about the kind of drugs that are implemented there and the kind of their use. So when do we know when someone needs them? So most patients will be, COPD patients will get some sort of pharmacological treatment to assess the patient for what medications they may need. Is based on an individual assessment of their symptoms, exacerbation risk, and their blood eosinophil count. The assessment is called the ABE scheme. The purpose of the ABE scheme is to provide a clinical guidance to prescribing their pharmacological treatment. So this is what you're going to use to kind of determine like what degree of these medications do they need, what mix do they need, how much do they need to prescribe for them. So it's divided into 3 categories: the A, B, and E. A being the less significant, E being the worst, or worse, to need more control, and they're separated by the severity of the disease process. So category A requires the least amount of pharmacological treatment due to the reduced severity of the symptoms. Group B requires additional pharmacological treatment to group A based on the increased severity of their symptoms. Group E, even more so, based on the very severe symptoms that they have. So group A consists of bronchodilator treatment based on the effect it has on breathlessness. A short or long-acting bronchodilator can be used. A long-acting bronchodilator is preferred treatment, but it's more expensive and less available. Depends on the insurance they have and their actual prescription. They may end up doing a short, even though they really need a long, because in this country, it all comes down to what you have for your insurance and what is affordable, because these things can really jack up in prices, especially the long-acting ones. And the short-acting is preferred when the patient presents with only very occasional breathlessness. That's what I'm talking about, more like that quick relief if they need it, only in need of it. Group B consists of a LABA and LAMA combination, so that long-acting bronchodilator or beta-2 agonist plus that long-acting muscarinic antagonist. The study showed that combination is the highest ranked treatment group to reduce COPD exacerbations. So that's what, if they're having a fairly good amount of exacerbations, they're going to get prescribed this if it's not, nothing is indicated elsewhere. So group E consists of that as well. You might up the dosage on those 2 medications if it's not being effective to that point. And you may possibly indicate for an ICS on there, that inhaled corticosteroid, showing that scale we had earlier. If they, are not at risk for a lot of pneumonia, if they have asthma, you definitely want to do it. And it has been shown that trio combination is superior to just a LABA, the ICS, or the LABA and the LAMA ICS in COPD, or the LABA ICS is not even encouraged for COPD patients. So you definitely want to go with that trio if you get to the group E, if the ICS is indicated for that. So sorry for this picture being a little bit blurry, but this kind of breaks it down in a way that you can visualize it here. So group A here on the bottom left, a bronchodilator, could be short acting or long acting. You see one or more, or 0 to 1 moderate exacerbation, not leading to hospitalization. And MRC, I believe it says less than 2. I'm sorry about this being off there, less than 2, and a CAT score of less than 10. And then group B, the LABA and LAMA, is in the same kind of category as that as well, except for the MRC and the CAT change a little bit, I believe. And then group E, LABA plus LAMA, if they have over 2 or more moderate exacerbations and at least one leading to a hospitalization, you want to consider adding that LABA and LAMA and increase the dose there with them. And if the ICS is indicated with their blood eosinophils being over 300, or if they have asthma, you might want to consider putting on an inhaled corticosteroid as well.